Thank you so much. We're really excited, and I will get all official right now. Good afternoon and welcome, everybody. Thank you so much for showing up today for EPI 291 and the CHPR seminar series. My name is Jeffrey Hotch. I am a professor of health economics and one of the coordinators for the seminar series. I'd like to welcome you. I'm chief of the Division of Health Policy and Management, and today it is our special treat to welcome Dr. Sarah Haynes. She is an assistant professor in the Department of Pediatrics at UC Davis. She trained as an epidemiologist and health services researcher, focusing her research on improving the delivery of telehealth interventions for children with chronic diseases. Dr. Haynes uses mixed methods and implementation science approaches to design and evaluate telemedicine and remote patient monitoring programs. Today, she'll be speaking to us about designing a low-resource intervention to improve transitions from pediatric to adult endocrinology care for adolescents with type 1 diabetes. The objectives of her talk are to promote the understanding of the challenges and risks facing adolescents and young adults with type 1 diabetes. 2, the components of a low-resource transition intervention for adolescents and young adults with type 1 diabetes. And 3, her talk will promote the understanding of how to incorporate features of a 3-stage human-centered design process into research and intervention design. Thank you, Dr. Haynes, for sharing your research with us today.
Thank you, Dr. Hodge, for that nice introduction. I am really excited to be here today, so thank you for inviting me. As Dr. Hodge mentioned, I'm going to be talking about designing an intervention to improve transitions from pediatric to adult endocrinology care for adolescents and young adults with type 1 diabetes. Let me see if I can, there we go. So this work was supported by a grant from NIDDK through the DREAMS Center for Diabetes Translation Research under this award, and that's also a joint venture with the American Diabetes Association. And then components of this work were also supported by a research award from the Children's Miracle Network. And I have no conflicts of interest to disclose. I wanted to start off with a few acknowledgements of the many people who were very involved in this project. So my very close colleague and collaborator, Stephanie Crossan, in the Division of Pediatric Endocrinology, Erin Convoy-Heiser and Allison Ruggiardo, who facilitated our interventions and helped with the design. Patrick Romano, who mentored this project, Chava Lopez, our CRC, Abby Leon and Miriam Sarkisian, who were students involved in the qualitative analysis portion of this, Bethany Kwan, who helped with coming up with some of the frameworks and the customer discovery process, and then Leanne Simmons, who supported our application for the DREAMS grant. You already mentioned or Dr. Hutch already mentioned our learning objectives, so I don't think I need to go over these again, so I'll just start. So the problem we are setting out to address here is the problem of transitions of care for patients with type 1 diabetes. So as you may know, type 1 diabetes is a very serious medical condition. It affects more than 300,000 children in the United States, and there are significant impacts on health-related quality of life, missed school days, missed work days, both for parents and for adolescents and young adults, and significant healthcare costs. Routine visits with an endocrinologist are a really important part of optimal type 1 diabetes management. The endocrinologist reviews the charts reviews the insulin and glucose data to make sure that someone is optimally managing their diabetes so that they don't end up with a life-threatening emergency. Current guidelines from the American Diabetes Association recommend that a patient be seen at least once every 3 months. Transitions from the pediatric to adult care are difficult. We might just know this intuitively since we've all been an adolescent and a young adult at some time in our lives. But during this period when adolescents are really taking charge of their own healthcare and their own diabetes management, there can be slips. So this period is highly associated with lapses in care, reduced adherence to medication, and hospitalizations for diabetic ketoacidosis, or DKA, which is a life-threatening condition, or not condition, but a life-threatening emergency. So short and long-term effects on patients' health and well-being, and as well as on their social, educational, and career opportunities are the risks that we are really looking at here. And an estimated up to 1/3 of adolescents and young adults with type 1 diabetes fail to transition successfully to adult care within 6 months to a year, which is kind of what we're defining as the transition period, or what the literature has defined as the transition period, I should say. Okay, so there are interventions that can improve transition success, but these are not universally available. So some of these existing interventions include designated transition coordinator. So that might be a person whose full-time job is making sure that kids are getting ready to transition, that they know what they're doing, implementing checklists, following up with patients, making sure they have the education or special assistance that they need, and then following up once they get to adult care. Shared medical appointments is another intervention that's been used successfully to help kids transition, and that involves one provider seeing a group of patients who are the same age and who are going to transition to adult care. Case management. So obviously someone who similar to the transition coordinator, helping a person who needs assistance to make their appointments and get over scheduled with the adult endocrinology, and following up with them to make sure they are doing the things they need to do. And then some places have designated AYA clinics or designated AYA providers, so that adolescents and young adults stay in the same clinic they will transition in adolescence and then stay there a longer into adulthood, maybe up to age 26, until they're a more full adult, and then are better able to manage this transition themselves. But why are these not universally available? So as you might guess, high costs. These are all relatively expensive interventions. They rely on provider level changes, clinic level changes, and system level changes, which are not easy. And when we talked to systems about whether or not they were implementing these things, a lot of it was about high reluctance to add to existing staff burden and nursing workflow, which, these things are all obvious barriers probably that we all might guess make a difference. So our objective here was to design a low resource intervention that meets the needs of AYA patients and that can be feasibly adopted and implemented by existing providers and staff. Our underlying principles here. So there's kind of two basic underlying principles to this whole study. The first is designing for dissemination and sustainability. The idea here is really enhancing the fit between an intervention and the context in which it will be adopted. The idea being that early and active dissemination and sustainability planning will lead to better dissemination and sustainability. So dissemination, making sure the products are developed to match the target audiences, and sustainability, really focusing on increasing the likelihood of sustainment right in the beginning, in the design phase. So trying to anticipate barriers to sustainability and address them. And then the other kind of underlying principle is human-centered design. Meaning participatory design that engages stakeholders early. So we're not just like designing this and then asking people what they think about it, but really incorporating all of the key actors at the very beginning of the process. The idea here is that the final design of the intervention should reflect the values of the end users, again, to optimize the chance of successful implementation and sustainability. So this, we are using the Fit to Context framework for designing for dissemination, developed by Bethany Kwan and colleagues. And this is a 4-phase process framework for guiding the development of a health product or intervention or policy. And broadly, I guess I'm going to show in a minute which phases we're focused on, but we're really focusing in these conceptualization and design phases. So you can see that the idea is really making sure that we're fitting to context in each of these stages and asking ourselves questions about need and demand, capacity for change, contextual factors in these early phases. And then we are using a 3-phase human-centered design process. So our first phase, inspiration, really, what is the problem? Characterizing the problem. What are the potential solutions or opportunities for change? That's the ideation phase. And then finally, implementation, prototyping, and adapting our intervention in the real world. And this is kind of where these things fit together. These phases, these human-centered design phases match up with this fit to context framework. So our phase 1 was a qualitative exploration as well as literature review, obviously, to understand what's already been being done and what are the key components of a successful transition intervention. The qualitative study that we did included 26 clinicians on staff involved in providing specialty diabetes care across 4 University of California health systems. So we found here, I'm not going to go too much into this phase, but that there is a perception that transitions are an area needing improvement, even at these high resource academic medical centers, some of which have excellent transition resources available. They're not widely available to all patients. And at all sites, for example, many people have are serving patients that are at more remote sites or that are living far away. And there's also just a limited availability of these resources, even if they are available, which at many there are not. They are not. So the variety and levels of types of support available for these patients depend on the health system and the patient's distance from the health system. And then we also use these interviews to generate some ideas around intervention components that might be useful and feasible. We also did a literature review on components of effective transitions, including some of the gray literature available from evaluations or internal papers on transition programs and evaluations of transition programs, and then some of the tools like checklists, for example, that are being used in other transition programs. Our phase 2, which I'm going to go further in depth about, was a customer discovery process. For those of you not familiar with customer discovery, it is an iterative process that really focuses on identifying what the pains and gains are of these different types of customers. So as you might guess from the term customers, this method has a history in commercial product development and has been used for example, for developing pharmaceutical companies, but now has been recognized by public health folks and the NIH and others that, we really should be stealing these types of methods from people who are developing products commercially, since we have the same goal of getting the intervention to the most people possible and making the biggest impact. So in our customer discovery process, we start by identifying the key actors. So we identified patients as our end users. So that was adolescent and young adult patients with type 1 diabetes. Adopters and recommenders. This category includes pediatric endocrinologists as well as adult endocrinologists and parents and caregivers. Influencers, diabetes educators, decision makers, again, pediatric endocrinologists, division chiefs, department chairs. And then there's this fun category that they guide you to think about, which is potential saboteurs, which of course we love all the nurse managers and administrative staff, so not to be negative, of course, about any of those people, but just to say that they are very protective of their staff and their staff's time, and don't want all of these random researchers asking them to do extra things, which is totally understandable. So these were brief interviews with 42 of these key actors to understand the pains and gains for each group. So what are the things, when I say pains, I mean, like, what are the things that are making your job harder that potentially this intervention could help alleviate? And then gains, really, like, what is the motivation for doing this better? What are your kind of internal motivations? And then we developed at the end value propositions for each group based on these, which I'm not going to go into detail today, but our plan is to really go back and use these during the dissemination phase. Okay, so our interview question for patients during the customer discovery process. Can you tell me about your experience transitioning from pediatric to adult care? What types of things were you most concerned about? What were the main challenges and how did you deal with them? Is there anything that could have made the transition easier? What would an ideal transition intervention look like? And how would you define a successful transition? For endocrinologists and diabetes educators, the questions were, what is your role in transitions? For patients, can you walk me through a typical transition? How would you define a successful transition? How do you feel your health system department, division, clinic is doing? What resources are currently offered? How could transitions be improved? What are the main challenges and how important do you think transitions are, or improving transitions are for you, your colleagues, your patients' leadership, and what motivates you to want to improve transitions? Some key insights from our process. So again, we had 42 participants, 18 of these were patients between ages 26 to 35. So people that had already transitioned, and we were asking them retrospectively to think about this time and what could have improved it. So our customer discovery guide that we followed was asked us to focus on what is the most important job to be done for that person. In their own words with regard to the transition process. So for patients, for adolescents, it's really living a normal life without worrying about diabetes. The pains that we identified, and again, some of these are things that we expected to see. Like, for example, navigating the healthcare system is complicated, and that's something we kind of expected. And then some of these things end up being more of a surprise. So anxiety around the unknown, not knowing like one source of information where you can go and ask questions. People know that they can ask their doctor questions, but aren't going to email their doctor with every tiny question they have. So like that was one thing that people mentioned, just like a place to kind of ask these random questions that you have that come up while you're doing this. That we found that it's, again, overwhelming having to navigate many different systems, the health system, pharmacies, device companies, school, work. People reported that as an adolescent and young adult, they really lacked skills to ask for the accommodation that they were due by their work in school, or legally, I'm just like missing a word that they were entitled to. There we go. And advocating for themselves, explaining to someone like, I have to have my phone even though we're taking this test because I need to know if my blood sugar is low, or like, this is why I have to have maybe another break at work to have a snack or whatever, whatever it is. And then frustration around explaining diabetes to others. Again, you can imagine that as an adolescent, having an insulin pump or something different about you that people can see, and can be overwhelming to have to kind of constantly constantly talk about that. And people have a lot of misconceptions about type 1 diabetes. And so we heard a lot about that too. And then motivating gains from a transition intervention really were connecting, the ability to connect with others going through the same thing as them. And surprisingly, there was a lot less, like basically what we heard was that we were encouraged to disseminate this opportunity to people less on like, you might die of DKA or whatever. So that really wasn't, I guess that's like something that people, that, you know, you hear a lot from when you have type 1 diabetes from others. So that wasn't something that people were kind of, you know, that wasn't a really exciting feature of a transition program. So insights from pediatric endocrinologists. So the most important job to be done with this group is really to discuss the transition with patients and families and provide a referral to adult care, and to refer to a diabetes educator for additional education as needed. The pains for endocrinologists, again, some of these probably predictable, and then others maybe a surprise. So they really expressed distress about seeing their patients not successfully transition. You know, a lot of these doctors have seen these patients grow up for many, many years and have been in charge of their care, and then to see them floundering and not, you know, be the person that's responsible and in control of that is hard. There's also like a sense of discomfort around continuing to provide insulin prescriptions to patients that they're not seeing anymore. And so like, but that happens frequently where, you know, like someone will be not in pediatric care anymore and they were supposed to transition, but they haven't, but then they're like, I'm out of insulin. Can you please give me some? And so there's that kind of uncomfortable moment as well. And then there's a limited availability of resources, with which to provide patients, you know, like we'd love to give someone something else, but we don't like have it available. And then there's limited time to prepare patients for transitions in these visits, which, you know, we've all heard that story too. And motivating gains, wanting to provide high quality care. This is really important to our physicians, no surprise. And feeling good about being able to provide the additional resources that could help their patients. And finally, our key insights from diabetes educators during these interviews, their most important jobs, providing education and resources to patients transitioning to adult care. And that includes helping patients understand expectations about adult care and answering whatever questions they have. So their pains, again, limited availability of resources to provide patients. There are many online things and things you can read. There's diabetes camp. There's lots of things, but in terms of an intervention or a group that we can provide, that was something that wasn't very common. Frustration at being only able to serve a small number of patients. So if a patient, for example, had a parent who was very involved in making sure that they were getting the care that they needed to do this, but ultimately a diabetes educator has many patients that they're seeing, and so isn't able to give that attention to every single patient. And then also this idea of limited autonomy, worrying about following the rules set by nurse managers and hospital administrative staff, which can be a barrier to, you know, something like coming up with your own ideas for providing an intervention to patients. And their motivating gains are really feeling good about having additional resources to provide and potentially lowering the burden to provide their own transition education in the future. So phase 3, we took all of this information that we learned from our first 2 phases and turned it into this feasibility study. So the first iteration of the intervention, we had planned 4 virtual sessions once per month over 4 months. And the components identified through these first two phases. So we knew that it needed to be led by a diabetes educator, preferably who themselves have type 1 diabetes. We included this aspect of type 1 T1D mentors, we called them. And these were slightly older adults who transitioned successfully and can share their experiences and strategies. We included logistics around getting to adult care, so like parking, this is how you get to the building, this is where you park, this is how you do it, finding a doctor, all of those types of things, logistics around general type 1 diabetes management, including like if your device breaks, or like how do you call and request a new one? If you're going on vacation, how you do like, how do you get an extra insulin to take with you? Advocating for yourself, asking for accommodations, this like adulting with diabetes category, adult alcohol, drugs, relationships, traveling, driving, and then finally a transition plan developed by participants that could be shared with providers. So we initially envisioned that component as being a very major component where people would write out their transition plan and share with both the pediatric and the adult endocrinologist. Okay, so our eligibility criteria, you had to be a UC Davis patient who were also transitioning to UC Davis adult care with a type 1 diabetes diagnosis, aged 17 to 21, and CCS insurance. And type 1 diabetes is a CCS qualifying insurance. So yeah, okay, so we have 86 potentially eligible patients. 66 of these were initially contacted either during clinic visits or through study pages. 30 who were through study pages did not respond to further communication. 4 ended up not being eligible, and 7 declined to participate for the following reasons: 4 not interested in participating in research, 1 work conflict during the sessions, too much of a time commitment was 1, and 1 was not comfortable participating in the sessions in English, which was the only option we had at the time. We ended up having 25 enroll. 15 of these were recruited in person, 10 through study pages. 40% were identified as Hispanic Latino, 6 as African American, 9 as non-Hispanic white, 3 as Asian, 1 Native American Pacific Islander, and 7 other. The median age was 18, and the median years of diabetes was 4, although that ranged from 2 to 14. And employment status, we had 11 students, 3 were doing part-time work only, 1 had a full-time job, 5 were unemployed, and 5 didn't respond to that question. So in our first cohort, so out of 9 enrolled, we had 7 patients attend the first session, and only 3 participants attended sessions 2 and 3, and then 2 participants completed all of the sessions. So the expectation, here's some of the big things we learned from this first cohort is the expectations around video, having your camera on and being engaged in a video is just not realistic for this age group. I'm not sure, well, at least the population we had. So it was, at first we were like, okay, everyone turn your video on. We're all gonna be engaged in this. And that did not happen. So there were a few that did do that, and we did have more videos on when we encouraged that. But we also had some people who just dropped off when we asked them to turn their video on. So we may have lost some people there. We also had people that would have the video on or didn't have the video on, but were on there, and we were not engaging when we would like ask someone to speak up or whatever. But then when there would be like a vote or something in the chat to respond to, they would respond to that. So sometimes we would think people were not listening, but then they would like respond to a question in the chat or ask a question in the chat or participate in some way in the chat. So that we learned for future sessions to make more use of the chat and to put less stress on the video component. The patient-generated transition plans were not feasible in this setting. So again, we had this vision that all of these adolescents were going to we were all going to fill out these online transition plans together. And that did not happen. So no one wanted to actively do that during the session. So we again ended up changing that to be more of, here's an example. And we'd have the T1D mentors go through it themselves and give examples of like how they would do it. And then we I had that as a Google Doc, which was the preferred what we heard from participants was the preferred mode of doing the transition plan. And so we sent that to everyone so that they could do it. And but we didn't force people to fill it out during the session as we initially anticipated. We had very low engagement from the Division of Adult Endocrinology. So I think what we learned from that was that we want to create a plan that is not crucially dependent on engagement from that group. 4 sessions was too many sessions. So we ended up canceling the final session and then in the future planned 2 sessions only. We added topics about relationships, which was something that people had questions about. And again, I mentioned we added examples to the transition plan document. So in our second cohort, out of 8 enrolled, we had 5 participants attend. 4 of these also attended the second session. And I should also mention crucially that we, instead of having these be month to month, we started doing these consecutive weeks. So it was like 2 weeks, like this Thursday and this Thursday. And then the following Thursday. So the 2 Thursdays is what it was. So 2 sessions seemed sufficient. We got through a lot of things, not too burdensome, either for the facilitators or for the patients. So using chat, again, is a good option for those who don't want to speak up. We added more T1D mentors here, and that sparked more engagement too. And just having a variety of different people from different backgrounds, different perspectives of how they're managing their own things, different tips and tricks and stories. That was like a really beneficial thing and sparked more engagement from the participants. We also started doing our CRC just would text people like 5 minutes before the session started, or what right when the session was starting, and then we'd have people like kind of right away like getting on. So that's another pro tip for adolescent virtual interventions. And then we also added topics about driving and traveling in these sessions. Okay, our cohort 3, we had a long lag between enrollment and then the actual session, which in retrospect was a mistake. So we had really low participation in that session. We had 8 enrolled, only 2 attended the session. So I think we needed more reminders and ideally a closer time period from when people are being enrolled to when they're actually participating. So from all of the things you've heard so far, here is where kind of what we have identified as our core functions of our intervention. So this, again, education and discussion on adulting diabetes facilitated by a certified diabetes educator, asking for accommodations at work or school, advocating for yourself, talking about diabetes with others, understanding the relationships between diabetes and alcohol, drugs, stress, sleep, pregnancy, driving, managing diabetes while away from home, and being prepared for emergencies. And then we have education and discussion on navigating the healthcare system as an independent adult with type 1 diabetes. That's things like making appointments, asking diabetes-related questions and finding information, filling prescriptions, implications of insurance changes, communicating with device companies, obtaining additional supplies and replacement devices, and expectations for adult care. An interactive exercise, working through a detailed transition plan, providing a template and talking through examples as a group. T1D mentors sharing their experiences between 2 and 4 during each session, provide stories and different perspectives. An open discussion between peers with type 1 diabetes, so providing time between topics and at the end for open discussion. Opportunities to ask any questions about T1D management to peers, T1D mentors and facilitators, encouraging them to discuss, and having the T1D mentors facilitate discussion and questions. And again, these mentors were really an incredible, I was the only person in the session who did not have type 1 diabetes, and I didn't really talk except for just at the beginning to say, like, you know, the research and consent related things. But otherwise I was just watching, and they just did an amazing job coming up with icebreakers that were related to, you know, what's your favorite low snack, or, you know, all of these things. So that was really, really great. And assessing individual needs and providing additional resources. Then we did qualitative interviews with participants and facilitators and mentors. We had 12 participants and 7 facilitators and mentors complete interviews. And then we had the interviews transcribed, and we uploaded them into Deduce qualitative software, and did a qualitative content analysis, which included line-by-line coding by 2 researchers. Honestly, this was a little bit surprising to me, because I would sometimes leave the sessions and be like, oh my God, like no one was talking. I just like that, you know, whatever. We had it, like I said, we envisioned this as like this big support group, and people were, but then we got such positive feedback from participants about how much this helped them and increased their confidence and all these things. So when I would be doing these interviews with them, it was really honestly shocking, but encouraging. So all of them that we interviewed said that the intervention had really increased their confidence, and were confident they would attend their first adult visit. The most valuable components people highlighted were hearing from others with type 1 diabetes. A lot of people said, I've never talked to anyone else with type 1 diabetes before. So, and then an idea of what challenges may lie ahead. And then agreeing that this Google Docs was a helpful place to keep our transition plan. Okay, here's some quotes. I thought it was very informative because I've been nervous about transitioning to an adult endocrinologist, and I found it very helpful that it gave me the peace of mind it would be easy to transition. I just liked being able to, connect with the other people and relate to them. And, you know, there's nothing better than having someone talk to you about diabetes than a person that actually has diabetes, because they know what you're going through, because they're going through it the same. I felt comfortable sharing the group because I felt like everybody has gone through practically similar or the same experiences I've had growing up with diabetes. So I'm like, it wouldn't be talking to someone who didn't know anything about diabetes, because they won't get it. I was scared to be social about it, but then I realized there's other people that are open about it, and they have no problem with that. Like letting people know what's going on with me and letting other people know that I'm diabetic. And then the last one, and that's why I kind of just joined this, and to help me prep for that, so I know what to do instead of being lost. And I would say it did meet my expectations, because I just wanted to know certain stuff, and that's basically what we all discussed as a group. And it was honestly really nice to talk to other people who are also a type 1 diabetic. We also did a short survey of our facilitators and T1D mentors about the feasibility and appropriateness using these 2 validated 4-item measures, the feasibility of intervention measure and the intervention appropriateness measure, and they had good scores. I mean, obviously do with this what you will with this very small group of people who are very involved in the intervention, but we did it, so here it is. And then this is kind of like what I think of as maybe our main outcome, along with that list, the table of components, is this logic model for a virtual transition for AYAs with type 1 diabetes. So you can see our problem, our input, our mediating variables, and our outcomes that we're hoping. And this is kind of what we're hoping to build on in the future in terms of future studies. So our next steps will be to map our intervention components onto a theoretical behavior change framework, explore important contextual factors and potential barriers at other sites, finalize our core functions and develop implementation strategies, and then hopefully do a randomized pilot of our intervention. Okay, that's all I have.
Thank you very much, Dr. Haynes.
Mhm.
If you have questions for Dr. Haynes, please feel free to ask them in one of three ways. You could type them into the Q&A or into the chat, whatever you have access to. You could turn on your camera and actually raise your hand, or you could do the virtual raising of the hand that looks a little something like that. So 3 different ways to ask Dr. Haynes questions. Dr. Haynes, I have a question for you.
Oh, yes, please.
You have a PhD in epidemiology
That is true.
from the University of California at Davis. Am I saying that right?
Yeah.
So how do you end up getting from PhD in epi to 3-stage human-centered design and implementation science kind of stuff? Can you tell us a little bit about that journey, about how you found what you needed and how you knew you needed it?
Sure. Yeah, my dissertation focused on adherence to weight telemonitoring for patients with heart failure. I've always been very interested in the idea of using interventions, and the idea that even if interventions are great, if people aren't able to use them, then they won't be effective. So that interest then led me to, I did a 2-year program after my postdoc in implementation science at UC Denver. And that was a very fun program. And so I've just gotten deeper and deeper into this implementation science space. And so that's my answer. Yes.
That sounds good. Do you think as you go to apply for maybe larger grants, is there something special about implementation science and the stuff you applied that will give you some competitive advantage because you maybe have a better understanding of what will work and what won't?
That is the plan. So I hope so is the answer. Yeah. Well, there's increasing interest from NIH and other funders on incorporating a dissemination and implementation science component. So I do think that is important, and we are going more towards that as the norm in terms of designing interventions that are, you know, yeah, going to be used by people.
Super. We have 2 questions that have come up. First, I'll ask Brooke if you feel comfortable to ask your question, and then we'll ask Bill, and then we'll ask Dr. Ducor.
Yes. Hi, Sarah. It's Brooke. Good to see you.
Yeah.
Question about the grant secured timing in this. I like the phase 1 and the phase 2, the qualitative exploration and lit review, and then the customer discovery. I see that could kind of happen either before or after funding was obtained, but when in this work did you have the funding, and have you had it in other projects where you had the funding either before or after those kinds of phases?
Yeah, that's a good question. Especially because, yeah, those things do take time. So the answer is that Stephanie Crossan, my colleague Stephanie, we got a Children's Miracle Network grant that we worked on together, that was focused on, that included the qualitative study across the 4 UC systems. And so we had kind of a little bit of pilot funding for that through that. And then that was the customer discovery too. But that didn't pay for my time. But it did pay for students to help do the qualitative coding, things like that. And then yeah, we did then after that for our little feasibility trial, we did get funding for that through NIDDK. So yeah, that was the split.
Thank you for your question, Brooke. Will, I see you've typed in a question. Do you feel comfortable going off of mute and sharing it?
Yeah, I can go ahead and ask it.
Thank you.
Yeah, great presentation. So I used to work at a sexual health clinic, and we had a program where we did youth education, and we had like a comprehensive sexual education class. And we found that when we offered like a small incentive for students to participate, we had way more people come. So I wonder if it's possible to like motivate people to attend by offering like a small like incentive, especially since like the research shows how much diabetes can cause on the back end. So I wonder if like that little bit of prevention in the beginning to get people in the door may be a possibility.
Yeah, so I should have mentioned this. We did pay people to come. We paid them $30 per session. And we did that using a what is that platform called? It's the one where you could basically, it's like a gift card, Tango, where you get a gift card from Tango, but then you go in there and you can pick whatever gift card you want from like a million places. So we did do that, and I think that was a big motivator and why people came. We did that for people participating in qualitative interviews too. But then people still didn't show up, so I don't know. I don't know. I don't know what the answer is there for improving attendance, but yeah, we will see.
Thanks for that question, Will. We're going to hear from Dr. Ducour and then Dr. Haddad. Dr. Ducour?
Yeah, the whole area of transition has become obviously very important, and it's one of the drivers we're getting from HRSA in terms of hemophilia care. But we're set up differently because we have a seamless, unified system between pediatrics and adults rather than siloed, so that there's no cutoff. I mean, people sort of slide from one side to the other, which I think facilitates the transition. Of course, we also have money to pay somebody to make sure the transition's ongoing, but that's a federal push that's been placed on us.
Yeah, and I will say we are doing more things now than when we started this project. We have a work group now, and we're implementing some checklists that are in the EHR, and yeah, and so I think people are interested in this, and it is moving forward. And I guess my thoughts are that an intervention like this kind of in spite, I think what we learned from this is that even if you have even if we have a more seamless system that is kind of achieving that maybe primary outcome of getting kids to their adult appointment, I think we found that there is some other value in this peer support and education component as well, that I think so hopefully it will end up being both, and they'll both fill important roles. But yeah.
Thank you for that question. And Dr. Haddad?
Yeah, thank you. This is a nice presentation. Thank you. My question is, when you got this group discussion of patients, did you have to get a formal consent for them to, because they're going to end up seeing each other, or is it, it's just
Yeah.
okay to sign?
Yeah, no, we did do a uninformed, our clinical research coordinator did an
Consent?
informed consent with them. Mhm.
Okay, thank you.
Good question. Do you want to follow up on that, Dr. Haddad, or does that answer your question?
No, that answers my question, because, it's always comes up like teaching people and transition as a group, or whether you have a group discussion where you bring up all the problems in one group and discuss it and address it. It's a group of patients, and that's a problem. And their information has to be protected. That's why I'm asking.
Yeah. We also made the decision to try to limit the other people that were invited to the group, because we had other folks kind of request like, oh, could I come? And see whatever. And so we kind of made the decision, for example, to not include the endocrinologists and like some of the other staff people or things. And I really think it was beneficial to have it just be people with type 1 diabetes in the group.
But you never know, like if they're online, you never know who may be watching. That's the thing, like
Yeah.
we don't have control over that.
Yes. Yes.
Super. And we have time for one final question. Someone anonymously put in the question and answer section a question which I can read for you to answer. It says, have you considered building an app that would allow patients to customize their transition plan based on what they identify as potential challenges during this phase of their care? Could also build a chat system so that they can access peers, diabetes educators, etc.
The answer is no, I have not considered that. And the reason is, I guess, I'm trying to think of how to put this. I just don't think that is, I think like getting someone to use an app, like, right, like I've been involved, in the past in the development of apps or prototypes. And ultimately, it's very hard to get people to actually use those things, to develop an app that is high enough quality that it like meets the people's standards of like what an app should be, like just what people are used to is apps developed by super app creators. And I don't know that I would say that is a high priority, for our participants or for anyone. And then the question about like having chat access to peers and stuff. I mean, there's just so many complicated things there that that is not a road I personally want to go down.
Super. So before I ask you, Dr. Haynes, for your final thoughts for today, I'd like to remind the seminar group and people who might be watching this recording later on that our next seminar is not next week. We'll take a break for the holiday, but our next and final seminar for the fall term will be on December 4th. And again, you can get that information from the center's website, or you can email Bill or me. But basically, no seminar next week. The one on December 4th will be our final one for the fall term. Dr. Haynes, we have a couple minutes left. Can you share with us maybe your final thoughts for today?
My final thoughts. Well, my final thoughts are that I think, yeah, I think if you're developing an intervention, asking people what they need and want is a good idea. So hopefully that's the the main takeaway. That's my personal main takeaway. Yeah, hopefully we are going to be doing more for transitions for our type 1 patients also. Those are my takeaways.
Super, Dr. Haynes. Thank you so much for your time today and sharing some of your research and insights with us. We really appreciate learning about what you're doing.
Thank you so much for having me.
And take good care. Bye for now.